You're listening to Healthy Discussions, a podcast supported by the Healthcare Leadership Academy, where we have conversations exploring big ideas in healthcare with our guests. I'm Zack, Hassan, a junior doctor from Scotland. If you're interested in how we can make the health system better, then this is the podcast for you. On today's podcast, I'm talking with Carey Lunan about whether the NHS needs to be more realistic. She's a GP and chair of the DeepEnd Group, made up of the 100 GP practices in Scotland's most deprived areas. We discuss the pressure on frontline services, how to respond to rising public expectations, and to what extent doctors should advocate on health inequalities for their patients. I hope you enjoy. Carey, welcome to the podcast.
Thank you, Zack. Good to be here.
So, working with health inequalities has always been a bit of an attraction for you, hasn't it? I'm just wondering if you can tell us a bit about how that started for you and what made you want to get interested in that.
Yeah, thank you, Zack. Good question. It wasn't something that was particularly highlighted during undergraduate years. I was aware of it, but I don't think I kind of developed my interest and passion around it until I started my GP training and then working as a GP. And I haven't always worked in very deprived settings, although I have largely worked in very deprived settings. I guess I became quite aware early on working as a GP that I felt the NHS needed to be at its best where it is needed the most in terms of being able to mitigate health inequalities for those people who really struggle to use the NHS and access healthcare. And I became interested in working in more deprived areas because I think that general practice has a really key role to play because it's out in communities and you know, kind of offering long-term context care. So I moved from a less deprived area to the homeless practice in Edinburgh, where I worked for 5 years from, I think it was 2010 to 2015, which was a fantastic and very humbling experience, to be honest, working there. And then I moved to Craigmillar practice, also in Edinburgh, also a deprived area. And I guess became very interested in the other roles that I've done along the way, working within the RCGP as its chair, also sitting on its ethics committee, also leading on work around the interface and patient engagement about the role of organisations like the college and also the role of professionals like GPs to do this work. So it's become, I guess, a kind of very personal and professional area of interest for me, and I feel very passionately about it and can't imagine doing any other kind of work now.
And how is practicing medicine at the DeepEnd different to practicing medicine elsewhere?
So I think there are obviously core elements of the job that are the same no matter where you work. And I guess I'm largely going to reflect on working as a GP because that's what I do, that's my specialist area. But the nature of how that medicine is delivered can feel quite different if you're working in an area that is very highly socially deprived compared to working in an area that is very affluent, for example. What we often find as GPs working in the deep end or in more socially deprived areas is that consultations are often more complex and more intense. They are often kind of infused with social complexity and poverty and the effects of poverty that mean that consultations are rarely straightforward. And where you're trained, you know, in medical school and through GP training to take a story from a patient, maybe do some tests, maybe make a diagnosis, offer some treatment. That feels like it's not often possible in that very simplistic way in more deprived areas, and there are lots of factors that contribute to that. Some of it is that many of our patients struggle with literacy, functional literacy in terms of being able to read and write. Some struggle with health literacy and being able to understand information around healthcare and health conditions. Often our patients don't have English as a first language, so we have translation challenges that come into consultations. And often the advice that we give is not always possible for people to follow because they maybe don't have the social networks that allow that. They maybe don't have the financial opportunities to take that up. Our patients are more likely to miss appointments in secondary care if we refer them on because they struggle often with the complex system that is the NHS, or having transport to appointments, or having, a lifestyle that allows them to be able to plan ahead and make appointments when things can often feel quite uncertain and unpredictable, with more chaotic lives. And I think as well, we can never underestimate the impact that poverty can just have on people's day-to-day life. And if you're struggling to make ends meet, to get enough food on the table, to pay bills, to keep your house warm, then healthcare needs can fall quite far down that list of priorities. And so it's rarely a straightforward way of delivering medicine in a DeepEnd practice compared to other practices, which I recognise have different challenges, of course, but that's from my own experience what's been different from moving into those kind of areas.
Mm-hmm. Just from my own experience, being in Craigmillar, that community aspect of being in general practice, you know, being part of the community like that, you kind of see the issues that people have, and you kind of that makes you reflect on the causes of them a lot more. And
Yeah.
I wondered what kind of lessons you've learned about how we fix things like social inequality or health inequality or poverty, because you know if you're working as a GP in this area, you must, I can sense that there's something you feel you can do about it. Maybe something we can all do about it.
Yeah, I think that's a really important question, and I think you're right. When you start to work in those areas, and when you have placements as a student or as a trainee in those areas, there's a lot of learning that goes on that isn't necessarily covered in formal training around, what drives the differences in health outcomes from people living in deprived areas compared to living in affluent areas. Um, and in terms of the impact that healthcare can have on addressing health inequalities, if you take healthcare in its purest form, it's probably quite a small overall impact if we were just thinking about what can we do within healthcare to change that, because so much of what drives poor health is related to low incomes or insecure employment or insecure housing, or poor educational attainment, or the
Mm.
welfare system. There's so many other things that impact on people's health. But I think for me, the role of clinicians, both at a kind of patient level, on a one-to-one relationship with patients or within communities, underestimate the influence that they can have as advocates for their patients. And so I think that, we as GPs can sometimes feel quite overwhelmed by systems and quite tired and feel like what we're doing isn't making a difference, particularly when things are stressful, like for example during the last year with COVID. But I
Yeah, you,
think
you preempted my
that
next
when we
question
do,
there.
yeah, when we do take more of a proactive advocacy role, it's incredibly rewarding and it's really valued by patients. And we probably don't do that as much as we could because we maybe don't know how to do that as much as we could. And so just thinking about an example within Craigmillar, for there, we have a number of voluntary sector and third sector agencies that we work really closely with out in the community, and that we would really struggle to manage our daily work if we didn't have access to them. And there was a voluntary agency next door to the practice that offered help with benefits, with claims, with volunteering, with writing CVs, applying for jobs, and just general support. And their funding became fragile and they were at risk of losing the service, which impacted on lots of our patients. So we thought about some practical ways that we could advocate, such as writing template letters for MSPs, or getting a petition signed, or writing an article for the local newspaper. And what that did was both, I think, let our patients know that we really cared about what was happening to them and we wanted to work with them to try and find a solution. Also helped our colleagues in the third sector know that we really cared about them and we were we were keen to use our circles of influence that they maybe didn't have to try and raise awareness of their plight.
Mm-hmm.
And it also gave us good experience and practical things that you can do within the practice to be an advocate for patients. So that was a powerful learning thing for me, and I've shared that quite widely with other colleagues, just because I think people want examples of what they can do, because otherwise you can feel a bit overwhelmed and a bit hopeless within a system that feels quite broken. And then, of course, if you do more national leadership roles or local leadership roles, you have influence there too and other opportunities.
Yeah, 'cause that's kind of an inspirational story actually, because I suppose the way that I think, well, the other option would have been to say, well, that's, it's nothing to do with us that the charity's been defunded. Like, we're just the GPs. So, and I think maybe a lot of people kind of expect that. So, I think it's heartening to hear people taking on, you know, responsibility that's kind of outside strictly, what is healthcare. And you spoke a little bit about the leadership roles that you've had kind of at a bigger scale. I'm kind of wondering, what lessons have you learned from that about the levers that can be, pulled to solve some of these health inequalities? Is it something that has to happen on a larger scale? Is it something that happens with, all of the GPs in a local area? What's the right level of kind of scale that to be addressing these problems on?
So I think there's probably multiple levels, but I think underpinning any significant change around this needs to be a change at a national level. So it needs to be viewed as a national priority to improve the health outcomes of the people who struggle the most and have the poorest outcomes. And that needs to underpin all policy development, so that every single policy that is developed has a sense check to say, will this worsen or will this improve health inequality? And consider that specifically as we develop policy, and particularly as we do things like recover the NHS after a pandemic. How do we make sure that the new normal is better than the old normal was for many, many people? And I think there is a lot of interest in that, and it's not an easy thing to fix. But I think if there is a will to do that and a desire to bring people around the table to have those quite difficult discussions, then that is really important. But I also think it's important that you have people within each health board, within each local authority area, maybe within each practice, who are also enabled to take a lead on health inequalities within their own workplace, within their own health board area, so that you have the kind of authority, the permission giving, and the kind of what good looks like framework from the top, and then that can be flexed at local level according to what the needs of your local population are. But I would love to see, for example, health equity champions in every health board, and I'd love to see practices enabled to have a health inequity lead within their practice. It doesn't have to be a GP, it could be anyone within the team who has a passion to do that. But their role would be thinking specifically about, how do we offer our services? Is there anything we could do better that would address health inequality? Do we know what's happening out in our communities? How do we engage with our communities and know what is going on out there that we might be able to lobby for or influence or advocate on behalf of? So I think there are lots of different ways that you can address that. And then, of course, policy is very important. If you design and write policy that enables those things to happen, then that makes a huge difference. And it's no longer just a kind of talking shop where everyone agrees this is important, but we don't have any firm actions around it.
Yeah. And maybe that's a good point to sort of introduce the sort of main question for this episode, which is, does the NHS need to be more realistic about what it can do? And the reason I'm posing that question is that maybe there's a sense that what the NHS is trying to do is unrealistic at the moment, or not working. Is that your sense of things as a frontline GP?
So I think probably the first thing I would want to say, just because of where we are right at the moment in history, is that I think the NHS has been pretty phenomenal over the last year. It has been amazing in terms of the resilience, the coming together, the keeping going during a pandemic, and an all hands on deck approach. So I feel very, very proud to have worked in the NHS during 2020, and I'm sure we will look back for decades to come and analyse the pandemic of last year and this year. But I think taking it more widely, when the NHS was set up in 1948, it was, of course, after the Second World War, and there was this massive collective desire to care for the most vulnerable and to raise the bar for the most vulnerable people who had the least, um, and to make care free at the point of access, and to give everyone a kind of better baseline quality of health, which it has achieved. But 72 years later, almost, 73 years later, of course, we have an NHS that is struggling to do what it wants to do and what it is expected to do. And there's lots of complex reasons for that. We've got, a population that's living for longer, far longer, so it's a victim of its own success. And people are living for longer with more long-term health conditions. We've also got, massively increased expectations around what the NHS should be providing. We've got widening health inequalities. We've got, a workforce that works at its absolute capacity most of the time. And so I think, if we want to see an NHS that feels sustainable, that caters for the people that need it the very most, we probably need to have some quite difficult conversations with the public who pay for it because it's publicly funded, tax-funded NHS, about what do we think are the priority areas for the NHS, and that conversation needs to be had, I think, ideally in a cross-party format, so that it's not a political conversation, it's not a point-scoring conversation about which seems most attractive to win the next election. It's cross-party. It's in everyone's interest for the NHS to be working well and not to be going through big changes every 2 or 3 years. And that conversation needs to be held jointly with people working within health and social care, so that we can engage with the public around these difficult decisions about what does a sustainable NHS look like, because otherwise it will start to fail, and it has started to fail in some elements. So I think, a long answer to your question, the NHS needs to be realistic and sustainable if it's going to survive for the next 73 years.
I think that was a really interesting answer, because you kind of talked about a lot of the reasons why it's not sustainable, and things that are relevant to kind of me working as a junior doctor, that kind of high human cost and the bureaucracy. You want to be doing the best that you can for every patient, but the computer system is down, so and that means everything takes longer, so you see fewer patients and there's more stress. And I'm just kind of wondering, you kind of asked the question, well, what does a sustainable NHS look like? And I want to put that question back at you. What does it look like?
I think we probably have to have some difficult conversations about whether we continue all the things that the NHS is currently expected to do, or whether some things have to pause or stop. And that is a conversation that needs to be had with the public, because they're not easy decisions to make. I know that over the years, decisions around those kind of things have been taken around whether or not aesthetic surgery is continued on the NHS, or operations are done without any clear clinical need for them to be done. So there have been attempts to try and make sure that we are offering NHS care on a strong evidence base, and around the greatest good for the greatest number, sort of utilitarian ethics, if you like. But I think, and I would say this, I guess, because I'm a GP, but I think that there needs to be a stronger emphasis on prevention and population health and shared decision making, realistic medicine, and earlier decision making and care planning conversations about what people do and don't want based on their personal preferences and what matters to them. And for me, those conversations are ideally placed far earlier on in the patient journey, out in the community, before they reach secondary care, before they're admitted to a hospital bed, before they're, in a sort of palliative care situation. I think we need to, as a society, get more comfortable about having those conversations, and we need to enable and empower the clinicians working out in communities to have those conversations too. And those conversations take time, and they take training, and they take trust, and they take continuity. And so I think that to have a more sustainable NHS, we have to have a stronger, more resilient, more robust, better funded, bigger workforce primary care segment of the NHS, and less of a focus on hospital-based services. Hospital-based services are crucial to the people that really need them, but I think we need to have much more focus on community-based healthcare if we want to have a more sustainable NHS overall, because those conversations around whether or not it's appropriate to investigate, to refer, how far people want treatment to go, whether the symptoms that someone is presenting with are more likely to be related to something that happened to them a few years ago that you discussed with them as a GP and are probably not concerning, but to someone who doesn't know them sound like they might be concerning. Those discussions are just easier and safer to have out in primary care. So that's what my argument would be, is shift it all upstream, make it more preventative, more based on population health, closer working with public health. We've learnt that during the pandemic as well.
I think there is some evidence for that argument as well, that more GPs means more things are kind of caught earlier when they're relatively cheap to treat, rather than waiting until a crisis and someone's in hospital and the costs that are associated with that. I was when I was researching for this episode, I found a paper that said that there's a 0.6 correlation between weaker primary care, which they sort of measured as kind of GPs per head of population, and higher costs. So like the more GPs you had, the cheaper it was to deliver healthcare. I'm just kind of wondering, are there other reasons behind that as well, apart from just is the reason for that it's the preventative care argument, or is there other things going on there as well?
Well, I think that if you have a strong primary care system and you have adequate numbers of GPs with enough time to have these conversations with patients, and you're having those conversations based on relationships of trust where people feel confident in coming forward earlier with symptoms that are worrying them, or you have GPs who are able to persuade patients to engage in screening programs where they might not necessarily have done that, because we know, for example, screening program uptake is much lower in deprived areas, so they tend to present later on with more advanced cancer diagnoses. So I think there is something about the nature of the relationship that is built over time, over lots and lots of encounters, and often you're not just looking after one person, you're looking after their family, and it's a multi-generational type of relationship as well. So I think there's something about the nature of the relationship and the value of time that allows us to have a series of conversations, and also the nature of our training as generalists, which I think allows us to consider how we make diagnoses in a slightly different way, because we do have the value of time and we have the value of previous knowledge of patients. So it's far easier for us in many ways to manage some of the uncertainty that can come with a patient coming in for the first time with lots and lots of different symptoms that are difficult to unpick and know which ones are the ones that we need to worry about. But we have the benefit of being able to see them back, to do a bit of reading, to maybe do some investigation, speak to colleagues in secondary care. But if that same person was to present to A&E or to present to the out of hours service, where there's no prior knowledge of what their history is and there's no real ability to see them back, then automatically that care becomes more expensive, and it has to be more risk averse, because they don't have the luxury of being able to say, let's see how you go over the next few days and we can do some tests if it doesn't improve. So I think it's something about the nature of the relationship, the training that we have, plus also the preventative aspects of being able to catch somebody earlier on.
As a junior doctor that's kind of pitched up for an out of hours shift, and has had to deal with a crisis with a patient I don't know on a ward that I don't usually work on, it's such a relief, even when the med reg is like, oh no, I've seen this patient earlier today, so even that's enough continuity to make a big difference.
Absolutely.
So yeah, so I can see that there's definitely, that's a convincing argument to me about, the continuity that you get in, when you're a GP out in community. um Something else I wanted to ask about was, whether you talked about this conversation with the public, and I wonder if there's like a tension now between, a healthcare system that's based on demand, and patients, wanting to be seen for what they want to be seen for, and then a healthcare system which is actually based on needs. Sort of, no, you don't need a referral, you don't need that MRI scan, or but what you do need is, these other kind of social interventions or healthcare interventions that you might not want to take. I'm wondering that must be something that you see kind of every day in a small way. Where's the right balance between those things?
So we do, you're right. We see it every single day and we have those conversations every single day. Um, and it's a difficult balance to get right. So, I guess ideally the NHS it should be based on need and not on demand, because that also drives sustainability. But demand and need can sometimes overlap quite a lot and feel quite grey. Um, And I suppose some of the difficulty for us as GPs is that we feel that kind of demands or expectations can be driven by circumstances completely out with our control. It can be driven by things that are reported in the media, by adverts for certain types of medication, by politicians' expectations of what they would like the NHS to be able to do. And so we're kind of left trying to have that difficult conversation about, yeah, that would be nice if we could do that for everyone, but here's the thing, we can't. And we've got to follow guidelines, we've got to, go with the evidence base, we've got to target our limited resource.
And I expect that doesn't make you too popular.
And it doesn't make you popular. So it's a difficult conversation to have if you want to maintain relationships sometimes. And I think there's also this separate rub. So you've got the rub between the needs versus demand aspects. And then you've also got the rub between the access versus continuity aspect, which is for some people just being able to have a conversation with anyone, it doesn't matter who, right now, because that is convenient and that fits in with their model of how they live their life, and it's driven by convenience and access versus the benefits of continuity, where you have conversations with someone that you know, but you might need to wait a day or two until that person is back and available to speak to you. And so there's this constant kind of rub between trying to maintain access, particularly where it's a more urgent problem and access is important, but also trying to promote continuity, because we know that continuity improves health outcomes and reduces
Mm.
mortality. So it's really important to have continuity, but it's harder to make that argument to younger, fitter people who don't need continuity as much, because it's more important for them to have access and convenient conversations. Continuity is really important for older people, people with long-term conditions, people with mental health issues. But it can sometimes feel quite hard to, even as a practice, as a service, design your
Mm.
system so that you manage both and you offer access, but you also try and promote continuity.
I can kind of see that the work of a GP is, juggling all of these things and trying to tailor them for the individual patient in front of you. It's a really hard job. And I kind of, I wanted to ask, if this is a larger conversation we need to be having with the public, or that, that the public need to have, is that a hard sell if, you're saying, well, some aspect of a more realistic healthcare system that, does things more efficiently, is you're going to have to maybe accept that you're not going to have everything on the day when you want it, and even if we could do that, that might not be desirable. How do you make people sort of not feel pawned off having that conversation? Because that's something else that people, especially people my age, can feel. You're not taking me seriously, this kind of
Yeah,
stuff.
Sure, yeah, sure, absolutely. And that would be a really bad outcome if people came away thinking I wasn't taken seriously. That is really damaging and not good at all. So I think that public engagement and public discussion around this is really important to get right, because we need to, and it's difficult because being able to have meaningful public engagement so that you have representative um, people from the population that you're caring for around the table having the discussion is almost never possible, because it's very difficult to get representative samples and discussion around this kind of thing. There have been some attempts with realistic medicine and citizens' juries to discuss what does realistic medicine mean, and I think that's quite exciting
Mm.
developments like that. But it is still really difficult to have a representative citizens' jury. So I think that there has been quite a lot of work done recently around trying to raise awareness of the fact that where you might previously have assumed this is something that you need to speak to your GP about, actually there are lots of other members of the team who can equally help you with this issue, perhaps more appropriately as well, because they may have additional training in it. So, within our practice, we have a physiotherapist who is far more skilled at speaking to someone about their chronic back pain or their knee pain or their neck pain than necessarily I am as a GP. We have a pharmacist who can go into much more detail about medication and dosette boxes and understanding, potential side effects and how to monitor medicines, and nurse practitioners or practice nurses with chronic disease management. And then, out in the community pharmacists have this wealth of experience around minor illness and being able to support people with that. Opticians, all things eye, dentists, all things teeth and mouth. So there has been some attempts, I think, in more recent years and months
Mm.
to do some public education around that. If you have these issues, these are the people you can speak to equally who will be able to help. And also there are online resources which are really useful too. The NHS Inform website is really useful, but it takes a while, I think, for people to change their behaviour, but also their understanding of where they can get help if it's not necessarily going to be through a conversation with their GP, which is what might have happened in years gone by. And that's just more difficult to achieve now because we don't have the workforce to be able to cope with that demand anymore. And it's better
Mhm.
to be done as part of a team.
I'm just thinking when I tell my friends like, oh, like that cold, you can go to a pharmacy for that, and and get it sorted out, and they can actually give you sort of not over the counter medicine. They're always like, what, really? I never knew that. And so it kind of makes me think, on the one hand, like we've still got quite a way to go with that, but people might actually be receptive to this kind of message. I'm interested to know a bit more about the citizen juries, because I've heard about this. This is like the idea that the government take, or the public sector takes a selection of people to kind of test out ideas for policies and see what people think. And what have those discussions about realistic medicine? Have you been involved in any of those, or um,
No, I haven't. So my reflections on it are probably not as informed as they would be if it was someone who had been involved in it. But I know that the citizens' jury was a big part of um, understanding the public response to the realistic medicine movement, if you
Mhm.
like, which kind of started back in 2016, and seeking, what the public's views would be on things like what does shared decision making mean for you? What does personalised healthcare mean for you? Um, what does kind of reducing unnecessary variation and waste mean for you? Because it's really important to understand that. So what we understand as doctors about shared decision making may be very different from what patients and people understand as shared decision making. And so,
Mhm.
unless we understand that, we can't alter our training, our teaching, our processes, our ways of doing it to make sure that it's as person centred as it can be. But I think the
Mhm.
concept of citizens' juries and other types of public engagement are really important to inform policy that is truly person centred. And it's hard to do. It is hard to do it well, but that doesn't mean that we shouldn't try and do it to the very best of
Mhm.
our ability.
I think what you have been doing in Craigmillar, is kind of like that kind of listening to the public, like on a smaller scale. Each time you're working in the community or you're meeting patients, and the example you gave about the charity, that kind of that's for me that's proof of concept that it works. Just to change topic a little, I kind of want to ask you about COVID and um, I think now the conversations are starting to happen about, well, how can we build or how can we get back to a new normal that's better than what we had before? And I'm just thinking, what do you see as the opportunities from COVID? I know there's been a lot of challenges as well, but what do we need to work on in order to be more realistic for people?
So I think there have been a number of silver linings in all the sadness of COVID. Um, and, some of that is around breaking down the hierarchies that we see within healthcare or within our society and recognizing what essential jobs are, what key workers are, who they are, and particularly within social care. A lot of patients living in poorer areas are often frontline workers, often essential workers, often unable to work from home, often don't have access to things like furlough schemes and loans, and so really struggled with a lot of the advice that was out there around keeping safe, um, and maybe more likely to be living in accommodation that is more crowded, with less access to green spaces, um, maybe not able to access some of the information that was coming out because it wasn't in their language, um, maybe not able to access the information because it was in a digital format and they had digital poverty. So there were a lot of reasons why the people that we cared for had higher levels of COVID in terms of serious illness and death. And we know that death rates were more than twice as high across the country in the most deprived areas from COVID-19, which is awful, but mirrors many other diseases that relate to social inequality. Um, so I think some of the things that have been silver linings have been breaking down that hierarchy and recognising the crucial roles that people do. And I hope that that will continue beyond COVID. But I think also recognising the really important work that link workers have done within practices to reach out to the socially vulnerable and make sure that they're still okay. We had our care coordinator team who are fantastic, phoning the people that they worried about the most in normal times during COVID who they just hadn't seen. And so these were people who they would often see reasonably regularly. They would come into the front desk just for a chat or to talk about something that was concerning them. Sometimes it was medical, sometimes it was social, sometimes it was related to mental health. But because we had to, from the very beginning, move to a digital model of healthcare where everyone had to phone first, and there are pros and cons to that, it meant that there were lots of people that we just weren't hearing from and seeing. And that was concerning. And so our care coordinators made a lot of proactive phone calls out to people to ask them how they were. Do you know we're still open? Do you know about the government advice about how to keep yourself safe? Do you know how to get a COVID test? Do you know about the financial support that's available? Is everything safe at home? Is money okay? And then they would signpost them on to services if they were finding that there was an issue. And for 8 out of 10 of the people they spoke to, they made an onward referral, whether it was to citizens advice or a financial advisor or a link worker or a mental health nurse or a GP or a practice nurse. So there were a lot of people out there with unmet needs that we just weren't hearing from, and that work felt really important, and just a tiny little snapshot with a reasonably small amount of people with this massive amount of unmet need. So I feel that that has been a really useful learning thing for us that I would like to see, how do we continue that beyond COVID? But I think in other things that have been silver linings is that for some people, they like the digital way of working. They find that it's easier to access. People, they don't have to take time off work. They don't have to travel. We've had a huge throughput over the last year of speaking to people largely on the phone or doing things over video consultations and seeing people face to face when we need to. But there is definitely a downside to it, and that for a lot of people, digital healthcare just doesn't work for them for lots of complex reasons. Either they don't have the technology or the broadband speeds at home, or they struggle because English is not their first language, or it's a sensitive or a difficult issue to discuss over the phone. That they might have brought up in a consultation had they come in to see you, possibly not as the reason they phoned in the first place, but the reason they were really there, which is something we see a lot as GPs. So I think that the digital has been both a silver lining and something that we need to be really cautious about moving forward, and not think this is a silver bullet for the NHS to move everything much more to online, because I think we risk missing out lots of vulnerable people if we do that. And I think, again, just looking at as secondary care reopens, thinking much more innovatively about how do we make sure that appointments and communication with patients, particularly in light of the big backlog that's going to happen, are that our appointment systems are much more patient friendly, that people are less likely to DNA because they haven't received letters or they've had an opt-in system that they can't work with. And that if they call, they can reschedule. So what we're concerned about is that the systems that we operate within the NHS are quite complicated and not very flexible, and so often our patients will be referred but will never ultimately make it to a hospital appointment. And I think we need to understand why that is better and do better as we build back the NHS. So there's lots of different things, loads of things I haven't mentioned, but yeah, there's lots of things to consider. How do we get to a better new normal for people?
There was something that you said that was kind of making me think that there's still a lot we can do to address. So you had people in the community, they weren't reaching out, and you were reaching out to them, and hopefully kind of modifying some of the risk of those inequalities. And around digital, you're worried about digital is that there's going to be people that are left out because they might not have the digital literacy to be able to understand how to log on to attend anywhere, or a video consultation or something like that. And I guess what it's making me think about is sometimes I encounter this argument that people kind of think, well, it's always the same. No matter how much we do, these inequalities are still going to be there, and we're still going to have to deal with them, and nothing that we really do is going to work. Or that it's to do with life choices, and people make different life choices, and there's nothing we can really do about that. Is that an argument you come across in your work? And I'm interested to know what your response to that is.
Yeah, so it is. And I think that there is very commonly a feeling of overwhelm when you start to talk about health inequalities, and people think, oh, that's too big. Of course it's important, but it's not really our job as GPs, for example, to be tackling health inequalities. That surely sits with politicians and policymakers, and we need to tackle the social determinants of health and improve housing and improve education and improve employment conditions and improve the welfare system. And of course, all of that is important. But I think what feels important as well is to do what we can as GPs, particularly, to mitigate against worsening health inequalities. And we can do that by improving our training, by improving undergraduate training, by improving postgraduate training, and by improving ongoing CPD around what are some of the practical things that you can do to tackle health inequalities within general practice, so that people have a better understanding of what it means and what they can do. But I also think that often it's a case of articulating what has an evidence base, what has been tried and tested before, what seems to work well, sharing examples of good practice, and influencing policy development if you've got the opportunity to do that because of the roles that you happen to be in. So, for example, in general practice, we know through the work of the DeepEnd that if you have financial inclusion workers in your practice, if you have mental health workers in your practice, if you have community link workers in your practice, addictions workers in your practice, longer appointments for people with the most complex health and social care needs, and protected time to come together to have those discussions, that health outcomes improve. And none of that is that surprising, but to have funded pilots that have been evaluated to show that makes a difference, there's an evidence base for that in general practice. So we need to upscale that and spread it out much more widely and not just have it as short-term funded pilots. And I think again we need to have much more emphasis on training so that people feel more I guess, equipped to deal with the challenges of working in more deprived areas. And some of that is about having a knowledge base around what types of conditions are likely to present and how do you manage them, the sort of clinical aspects of it. But a lot of it is also around what is the emotional labour of working in areas of high deprivation, and how do you recognise when you are becoming burnt out, or you're becoming intolerant, or you're losing compassion because there's no facility there to support practitioners to do this really quite difficult and emotionally challenging work. And I'm really interested in the concept of reflective practice, where you have a protected space with your team or alone to speak to someone who's skilled in being able to unpick what are the difficult dynamics and consultations that can create emotional labour for people working in more deprived areas, that if you don't understand what is going on, you just start to feel very disillusioned and very hopeless and very sabotaged, and you don't feel able to continue. So often the people that we're caring for in more deprived areas have had significant adversity in childhood, and they often struggle to trust people and to accept care because that's never been their experience in life. So when you come in as a kind of young, fresh-faced GP wanting to give lots of care because that's what you've been trained to do, it's very confusing when that dynamic very quickly becomes dysfunctional, and the patient that you're trying to help gets angry with you or says, that's not going to help, that's been tried, nothing helps me, no one helps me. And you think, I don't understand what's going on here, because we have nothing in our training that recognises, the psychodynamics of adversity and how that plays out in a consulting room. Mental health have much more supportive structures around this to allow them to understand it and feel supported and retain compassionate practice, but in medicine we don't. And so I think that there is a real need to recognise that this is a particular issue in more deprived areas, and that it would be fantastic to see recognition of that and support for more reflective practice to allow practitioners to keep going in this very emotionally charged often environment, and give them coping strategies and skills to understand what's going on and how do you cope with that and how do you develop your own resilience around that so you can keep going.
I'm wondering if the DeepEnd Group kind of plays into that kind of sharing experience, and whether you see, as a result of the DeepEnd Group, like practice being shared much more widely, the stuff that works gets rolled out, and the stuff that doesn't work, you can say, oh, well, we'll try this and it didn't work.
Yeah.
As chair of the DeepEnd Group, what are your priorities going to be going forward?
So I think that's a really good question, and I think that the answer to that is yes. The work of the DeepEnd Group is really useful to be able to provide an evidence base and share practice. And there have been lots of DeepEnd Groups established now throughout the UK, in Ireland, and beyond in other parts of the world. And there's an international DeepEnd Group now that's chaired by Graham Watt, who was the founding member of the DeepEnd Group in Scotland, with that explicit purpose, which is to bring people together to learn, to share practice, to create kind of community of frontline practice, if you like, because so much of the learning is common to all practices working in DeepEnd areas. But I think as well, one of my priorities is how do we move from a situation where we have short-term funded pilots that show that things improve to something that feels more sustainable in the long term, to funding that is more long term and more linked directly to deprivation. And one of the groups that I'm sitting on at the moment, which is a Scottish Government group, the Short Life Working Group on Health Inequality, and it's got kind of primary care remit, is to bring to that group, here are some examples of what works, how can we make this happen, how can we fund this, how can we match it, and how can we sort of move forward with it. And then there are, I guess, another key area for us at the moment, because it's very topical, is around COVID vaccination and how do we ensure that as we roll out the vaccine, we are flexible and innovative and proactive in getting to the hard to reach groups. So that would be groups living in areas of higher deprivation and BAME communities who've got traditionally low uptake, and they are also very high risk from COVID. So we need to be thinking, I think, as a society, how we make sure that those groups are protected early on in the vaccine rollout. So we're going to be hosting a virtual roundtable discussion on that in the coming weeks, just to come up with some actions on how we achieve that. What are some practical things that we can do based on previous learning and sharing across the country? So that feels both exciting and important, which is always a nice combination.
Yeah. Well, I wish you all the best for that, and it sounds like quite exciting work that you're going to be doing, trying to scale that up. I kind of wanted to come back to this issue of burnout, because I know this is something which is extremely topical amongst junior doctors and GPs, and there's a lot of people leaving the profession because of that, and COVID has kind of been the last straw. And part of me kind of thinks, that's horrific that that's even happening. These are people who have studied medicine for 5 or 6 years and really want to really dedicated to their jobs, who just are saying, oh, I can't do it anymore, I can't face going to work. Is there anything that you've seen that kind of works for that problem? And I'm just wondering, if anyone's listening to this podcast and they're wanting to get help, where should they look?
So I think practitioner well-being and avoiding burnout is something that I've been really interested in for a long time, because I think when you start to burn out, it it's not a nice feeling. You start to lose enjoyment in your job. You stop caring about the people that you want to be caring for, and you start to lose your compassion because you're not in a good place yourself. And so it's important not just for individuals in terms of maintaining their own health, but it's also important on a much bigger level for our healthcare system. So if you have a healthcare system that is staffed by people who are burnt out, patients will not have good experiences and care will be less safe because mistakes are more likely to be made, and the workforce will slowly be eroded because people are less likely to stay. So there are lots of reasons why burnout and staff wellbeing is important. That's not just about feeling better. It's about providing safe and sustainable services that are high quality, that people feel cared for within. And I think COVID has been a real stress test of an already stressed system. And there have been lots and lots of energy and attempts made to try and create specific resources around improving staff well-being, whether in secondary care it's around having dedicated staff room areas or access to food, helplines that people can utilise, access to psychology services within boards. And I think all of those things are enormously important. But I think probably the main things that impact on burnout in terms of clinicians is if they feel overwhelmed all the time by the levels of their workload, it just becomes impossible to do because people become tired and they start to worry that they're not doing the job well and they start to make mistakes. So the workload issues are really important to address as a kind of underlying driver for burnout. Workload has to feel safe and manageable, and that comes back to our earlier discussions about how do we prioritise what is really needed on the basis of need, not necessarily on expectation. But I think the other thing that really influences burnout is whether people feel valued, whether they feel valued by colleagues, whether they feel valued by patients, whether they feel valued by the system that employs them or that they work within. So relationships become really important as part of that. And I think what has been difficult over the last year is the disconnection that we've all felt in life with our own friends and family, with lockdown, but also with colleagues and with patients, because we've been at work, but we've been at a very different kind of work. We've been wearing masks when we meet with our teams, so you can't see each other's faces, you can't get a sense on how people are doing. You meet with patients over the phone, you don't get that sense of connection with patients. And so it just creates that low level anxiety, uncertainty, dissatisfaction with the work that we're doing and the teams that we're working within. So I think, we kind of have to go the extra mile to make sure that we combat that. There is a national helpline for NHS staff. I haven't used it myself, but I know there is one, and I know it's on the Promise.Scot website, which also has a number of resources for staff wellbeing as well. And I know that the BMA have good resources for staff wellbeing too, but I don't know if they are solely the answer, because I think that so much of what will prevent burnout in the kind of months and years to come is the opportunity to come together to talk about what's happened over the last year, and to be able to take annual leave and get a break from it, to feel like we're not being criticised unnecessarily in the media, or because of unrealistic expectations around how quickly the NHS is going to ramp back up. And I think, just being kind and caring for each other is going to be really important, because we're all quite tired now and quite stressed. So I don't think it's not an answer, but there are lots of things that I think we need to just be really careful around as we start to remobilise and talk of recovery, because our workforce is pretty universally exhausted. And what tends to happen as people get more stressed is we start to work more in silos, and we're not so good at working together. So I think it's also really important that we continue to build on and actively nourish relationships between hospitals and general practice and primary care, and we don't let that start to disintegrate and become unhealthy again. Because one of the great things during COVID was that coming together of primary and secondary care to think, how can we work together to get out of this? And so we don't want to see there being a competitive or unhelpful dynamic between primary and secondary care. It doesn't serve anyone well. Nobody feels good in that situation. So I think mechanisms to support those relationships feel really important as well.
Mm-hmm. And just on that last point you made about primary, secondary care coming together, do you think that infrastructure's part of that? Do you think it's about having a shared IT system? I think a lot of people listening to the podcast might not realize that, if you're getting seen in hospital, the doctor seeing you in hospital doesn't have immediate access to all of your GP records. It's not part of the same computer system. It has to be a phone call or an email sending notes through. Is that something which we have an opportunity to work on now as well?
Yeah, absolutely, Zach. I mean, that I've been very interested in building interfaces of care for probably the last 7 years, and I would agree completely that we don't have a system that supports necessarily good interface working. We don't have IT systems that speak to each other, that share data easily. So we've got a separate GP system, a separate out of hours system, and a separate secondary care system. And there's much more scope for being able to share relevant parts of the record so that patient care is more seamless and communication is better. But we've also got opportunities, I think, particularly as we're looking at how do we reopen more secondary care services, and how do we try and minimise unnecessary referral into secondary care while secondary care is recovering. I think there's massive scope to be looking at clinical decision support pathways, so dedicated email systems, dedicated phone lines for access to secondary care colleagues to discuss patients that are quite complicated, that we don't necessarily want to have to refer in, but we would like to be able to keep out in the community and manage more in the community than we currently are necessarily able to do. And having rapid access to colleagues in secondary care to have those kind of discussions would be just enormously helpful for patients, for consultants, I'm sure, for GPs. So looking at how we can embed those kind of systems in every specialty and every health board would be really useful. There are some dedicated email advice lines in some specialties, in some health board areas, but it's certainly not universal. And where they do exist, they're really appreciated. But I think the other forums that we need to think about are, I would love to see in every health board an interface group that is funded and supported, that has both consultants or hospital doctors and GPs sitting on it with an interest in improving the interfaces of care, sharing learning when things go wrong, sense checking, new processes before they're rolled out, to think about what might be the impact on other parts of the service if we do this. Looking at how communications can be jointly put out to the wider profession on how we work together better and communicate more effectively. So having dedicated interface groups is really important. And I think more opportunities for shared learning events as well, which is largely gone just because of the workload pressures of the last few years. But when you get people coming together, learning together, talking together, problem solving together, and you start to improve relationships, everything else improves because the desire to make things better is higher. So I think it's about creating the conditions to make sure that relationships can be functional and can improve and be healthy. And some of that will be through work shadowing, some of it will be through having dedicated forums for those kind of discussions and IT systems that speak to each other and make it easy for us to do the job well.
Well, it's been absolutely fabulous talking to you, Carey. Just before we finish, I want to kind of ask you just a couple of questions about, if there's anyone that's been listening to this podcast and they want to get involved in the kind of work that you're doing, and, you've been involved in some leadership positions to do with, the general practice and trying to address health inequalities. I mean, what career advice would you give people that are wanting to get more into that?
There's probably a few different routes that people can get involved in leadership. So one of them would be, I guess, getting involved with your local college faculty, and getting to know what work is going on locally in your area, but also at a national level. So that would be the RCGP if you're a GP, but equally all other colleges if there's other healthcare professionals listening. So getting involved with your kind of professional body at a local level and finding out how you can get into leadership positions there. You can get involved through the BMA as well. So getting involved in kind of local medical politics is often a good way into leadership positions. So joining your local LMC and getting involved in the work of the BMA is a good way. There are fellowship opportunities often post-training where you're given a kind of protected space. If you like to develop more of your professional interests, often it involves a further postgraduate study or taking on teaching responsibilities or running projects and developing leadership skills. So often there will be fellowship opportunities in your local health board area, so it's worth looking into that as well. And then the work of the DeepEnd, I think having a look on our website, which is on the Glasgow University site, that's where it's hosted, and just having a look to see if that's something that feels like you would be interested in. You can contact us through that site. We're on Twitter at DeepEnd GP, and you can follow us and see what's happening there as well. So there's lots of ways of getting involved, and I know that lots of medical schools as well have set up societies at an undergraduate level to get involved in the work of inclusion health too, if you're specifically interested in that. So there's lots of opportunities, but I think just speak to people, speak to folk when you're on placement, ask them, what other stuff have you done? Is there, particularly if they've done kind of portfolio jobs and they've done different things, I think just asking lots of questions and being open to opportunities when they come your way. And it's surprising how many doors will open, which is exciting.
Well, I'll make sure to link all of those the websites that you suggested. I'll put them in the description. And my very last question is there a book which you'd recommend to our listeners, something that's important that maybe influenced you, or something that you think people should read?
I really like, and in fact, I have it on my desk. So I really like a book called Intelligent Kindness, Reforming the Culture of Healthcare. I read it many years ago now. I've probably read it 2 or 3 times in total. It's by Ballot and Campling. But for me, it was a really powerful mixture of presenting the evidence for why kindness and compassion really matters in healthcare, not just because it makes people feel better, but because it improves outcomes for patients and it improves practitioner well-being, and also narrative. So it combined the evidence base and the narrative. And I have used that book so many times when I've tried to argue the case for better interface working, for supporting practitioner well-being, for addressing health inequalities. So I think it's a really good book, a must-have for the undergraduate and postgraduate curriculum if you've not come across it. And it's really easy to read as well. I read it actually when I was on holiday, when you could do these things lying by the side of a pool. So there you go.
And on that note, Carey, it's been absolutely wonderful to talk to you, and thanks very much for being on the podcast.
Thank you, Zack. It's been an absolute pleasure. Thank you.
If you like the podcast, the best way to support it at this stage is to tell your friends about it and share it on social media. You can use the hashtag Healthy Discussions or my Twitter handle @MontereyZack to tell me your thoughts about this episode. In the description, you'll find more about our guests' work and their book recommendations. Thanks to Health Education England North East, Health Education England South West, and Medics Academy for supporting this episode. All of us at the Healthcare Leadership Academy are grateful for their support.